Dear colleagues, hello and welcome to another episode of the Synapse e-learning series. This episode is the first of a series of 3 episodes which will tackle breast cancer surgery. For this episode, joining me is Mr. Gordon Caruana Dingley, Head of the Breast Unit and Chairman of the Department of Surgery, with whom we shall be discussing the diagnosis and management of breast cancer. Mr. Caruana Dingley, thank you very much for accepting our invitation to do this session with us today.
Thank you, Maria, for inviting me.
On to my very first question. Can you start by giving us a brief overview of breast cancer, including the incidence of breast cancer, its presentation, diagnosis, prognosis, and patient groups who are more at risk of getting the disease?
Breast cancer is the commonest single cancer in Malta, even though it mainly affects women, because about 1% are men. It is the commonest single cancer, and I'm talking about 350 cases, new cases every year. That was the peak amount, but now, in the last year or so, it was slightly less common. But we're still talking about one lady every day having breast cancer, new case. Now, most of these ladies present because they feel a lump in their breast. And they go to the doctor and then they are referred to us at the clinic. But we are getting increasing numbers of patients who are presenting to clinic in other ways. And one of these is people who would have undergone screening, for example, and they go for a screen mammogram and they're found to have an abnormality, and then we need to investigate further. We get some women who come because of family history. So they would have a relative who has breast cancer, and they are concerned that because the relative has this disease, they have a higher risk of getting breast cancer themselves, higher than the normal population. We also sometimes get rare representations, perhaps somebody who has a fracture of a bone, and it would be a pathological fracture because there's metastasis from breast cancer. But still, the commonest presentations are lumps, screening, and family history. And when these patients present to our clinic, they're first assessed by a breast care nurse who takes a questionnaire, goes into the details of her past history and family history. And when I first see these ladies, I start off by going into the details of the history and examining them. A clinical examination is still very important. And we also look for other forms of presentation. For example, women might have bleeding from the nipple. They have a rash around the areola, which looks like eczema, but it's actually Paget's disease. And at clinical examination, I actually feel this lump, if they present with the lump, and then at this stage decide what investigations to take. And the investigations we have are really imaging and biopsy. Now, imaging includes the commonest, which is mammography, but we also use ultrasound increasingly, and we're beginning to make more use of MRI. Mammogram is the gold standard. Even though it's the investigation used most, we have to accept that it's not 100%. So we can get both false positives and false negatives. And this is why it's important to combine the use of mammography with the clinical examination and also with other modalities like ultrasound. And of course, then the gold standard, the actual most important diagnostic test is having a biopsy. Nowadays, biopsies are done by the radiologists, usually under ultrasound control. And the machines are now so good that the radiologists can not only see the tumor, but they can see the needle, and they see the needle going into the tumor. So they're almost sure that they have a representative biopsy. Because of course, if you take a biopsy and miss the tumor and it comes back as benign, It's a false reassurance. Now, breast cancer is commonest in the older lady. Now, this is really probably over 60s, and as the older you go, the higher the incidence of the disease. But we're seeing it in young women all the time. I remember one young lady who was only 16, but this is extremely rare. We get quite a few in the 30s and 40s, though very often these are because they have inherited a genetic predisposition. Now, I'd like to explain that the majority of breast cancers are what we call sporadic. We don't actually know why that patient gets the disease herself. But there's a small percentage, about 5%, perhaps between 5 and 10%, that inherit a genetic mutation. Now, this mutation is a problem with the DNA. And because of this problem, because of this defect in the DNA, they have a much higher risk of getting breast cancer. So these are the high-risk groups. Again, we are becoming much more aware of this. The population are more aware of this, and I'm seeing a lot more patients asking about genetic testing, especially since Angelina Jolie and her mother had breast cancer. Perhaps we'll go into that a bit later on.
Mr. Caruana Dingley, significant effort is rightly so made to encourage breast screening, especially in women. How important, in your opinion, is breast cancer screening? And what are the latest recommendations regarding the age of screening and its frequency?
The rationale of any screening program is to test for a common disease with a relatively safe investigation to pick up the disease at an early stage, with the hope that by catching it early, it will be easier and more effectively treated. Now, with breast cancer, screening with mammography started in the 70s, especially in Scandinavian countries. At the time, patients were presenting very late, and the treatment was no way as effective as it is today. And these studies showed very large advantages in the cohorts of women who underwent screening. And I think it's still a very valid technique. But we have to have certain caveats. We have to explain and understand ourselves as clinicians, and we have to explain to our patients that this is not in any way an infallible test. So in no way does a woman who attends a screening program be guaranteed that she will not die of a breast cancer. I think this is fundamental. It will most probably help the patients who do go undergo a breast screening program. It will lessen the risk of them dying of disease, and it will also make the treatment simpler, because if they have a small lump, they can get away with a smaller operation, not a disfiguring operation, and so it is important. But there are problems. One of the problems is that the mammogram is no way is at 100%. So some 10% of women with a breast cancer will have a normal mammogram. So if they go for screening, this will be missed. There are also quite a large number of women who will have false positives. So these ladies go for the screen mammogram, they told there's something abnormal, they're re-imaged, perhaps they have a biopsy, and then they're told that there was nothing wrong. And this is traumatic psychologically for the patient. There's also the concept of perhaps over-treatment. So we are now picking up a lot of very early DCISs. A DCIS is a condition which, with time, could change into an invasive cancer. But there's no way that all of them do this. So we are now picking these up, treating them sometimes with very major surgery like mastectomy, when perhaps they would not have developed a cancer at all. So these are some of the problems. I don't think it means we shouldn't do screening, but it means we have to be cautious and we have to always work within the limits of what we have available. The age for screening, to start screening, is controversial. In Malta, the National Breast Screening Programme screen women between the ages of 50 and 65. And that is very common in other European countries. In some countries, like America, they started screening at a younger age, but there are problems with this. One of them is that breast cancer is less common in the younger age group, so you're not going to pick up so many cancers. But also, the breast is dense in a younger woman, and the tumor does not show up so well on a screen mammogram because essentially a mammogram is an X-ray that's measuring the density of the tissues. And so it could miss tumors in women with dense tissues. Hopefully there'll be some way of preventing disease, hopefully a vaccine, that's what I dream of, which will then make screening programs redundant. As an example, there have been screening programs in the past, like for example a screening program for TB, which isn't done anymore, because after the war there was a lot of TB in Malta, the treatment wasn't effective, and so there was scope for a screening program. But now we don't screen for TB. There are some other effective screening programs, and those are colon, screening for colonic cancer, and for cervix cancer, and pap smears that women start at a young age. And those, there is evidence that these three screening programs are effective.
Mr. Caruana Dingley, earlier on you mentioned the three main screening and diagnostic tools currently available. What are the respective strengths and weaknesses, and how is the choice on which diagnostic and screening tool to use in a particular patient made?
Every test has its problems, and so what we try to do in breast screening is what we call a triple approach. So we combine the clinical assessment, which is a history and examination. The second is imaging, and that includes mammogram, ultrasound and MRI, and the third is biopsy. Now, if we're talking about imaging, in the older lady and for screening, mammogram is the best of the techniques. Ultrasound is a very useful adjunct in this age group, so in the older lady, and it is very useful on its own in the younger ladies where we don't want to irradiate the breast and use a mammogram, which is not so effective in a young lady. MRI is a relatively new technique, and it's not easy to get an MRI because the investigation takes a long time, and there's a great demand for it from other departments. But we are now using MRI for patients who have a lobular cancer, which doesn't show up very well on a mammogram, and it can sometimes be multifocal, so we always take an MRI on these ladies, which are about 10% of our breast cancers. And we're exploring using it as a screening modality in young women who are at high risk. And those are the two indications, the strongest indications that we have for MRI. Sometimes use it in other conditions. For example, a lady has a lump and she has breast implants, and we're worried about taking a biopsy because we might damage the implant. So then we might think of using an MRI.
And what is suggested in dubious cases?
Well, when we have a doubt whether a patient has a tumor or not, we keep on investigating. And we have this ladder of techniques, and sometimes one or two techniques might not indicate that the patient has a tumor, but then on the next investigation we diagnose it. So we tend to use all the imaging we have. But what I want to talk about too at this stage is that in breast disease for the last 18 years we have regular multidisciplinary team meetings. And this is where we join up with the pathologists, oncologists, radiologists, radiographers, breast care nurses, the surgeons, students, psychologists, and we discuss every one of our patients. And like this, we use our joint expertise. We become friends, we work well together, and it has been proven repeatedly in the literature that patients who are managed by a unit that has a MDT have better results. And I'm very proud of that. We've been doing it for 18 years, and we discuss patients initially, so before they have surgery, and then we discuss them again after the operation, and sometimes we discuss them again when there are problems.
Mr. Caruana Dingley, can you give us a brief overview on the management options for a patient who has recently been diagnosed with breast cancer, including the point of referral, treatment required, and follow-ups necessary?
Most patients who have a problem in the breast, either pain, feeling a lump, perhaps discharge from the nipple, go to the general practitioner or family doctor. And family doctors then usually take the history and examine the patient, and most of them already have a very good idea when a patient has a tumor, and they refer them on to a breast surgeon. At Mater Dei we have a breast clinic, and we see all patients within 2 weeks, which is, I think, a very good time scale. When the patient comes to clinic, as I said before, we take a history and examine them, and then send them off for investigations. In the past, we used to first send them for a mammogram, then get back the result, and then send them for an ultrasound, and then get back, and then decide on a biopsy. Now our radiology colleagues are trying very hard to organize this all in one session. So we send them for what we call a one-stop shop. We have a mammogram, ultrasound, and then if the radiologist thinks it's appropriate, they take a biopsy, and we get the result quickly. Once we have these results, they're discussed at the meeting, as I said, and then I see the patient in the clinic, explain the diagnosis, counsel them, and advise on the best, what we suggest as the best treatment forward. Most of these patients will have an operation, which involves removing the tumor with a margin of tissue around it to make sure it's all removed. Now we actually take x-rays of the specimen in theatre during the operation, and that gives us an indication whether we've removed it all. And if we're not sure, we go back and take another piece during the same operation. We also assess the status of the lymph nodes in the axilla, because this is a very good indicator of whether the tumor has spread to other parts of the body or whether it's still within the breast. And we do this now mostly with what we call sentinel lymph node biopsy, where we use a radioactive tracer and the colored dye, which are injected into the area of the breast where the tumor is. And then we have a small Geiger counter, which allows us to find the sentinel node, which is the node which is most likely to be affected by tumor if the tumor has spread outside the breast. The patients usually go home the next day. They're seen by a physiotherapist, by a breast care nurse. We review them the next day, and then they wait until the laboratory result is available. We see them again after discussing the results at the MDT to advise on the next step, which is usually referral to an oncologist. But it's important to realize that every patient and every breast cancer is different. So we tailor the treatment to the individual and her disease. And some patients do not have surgery as a first step, but they might need what we call primary chemotherapy, which is giving chemotherapy to the patient in a way that we shrink the primary, and if there are any micrometastases, they will also be treated with this treatment. But this depends on what type of cancer they have, the age of the patient, and also the individual's wishes. Sometimes when there is a choice of treatments, we explain these to the patient and involve them in the decision. Breast cancer, besides being a disease like other cancers, has yet another aspect which is quite specific to breast, and this is the importance of the cosmetic outcome of the disease and its treatment. As you know, the breast in our society is very important. It defines the image of a woman. If you look on television and there are adverts of a car, there's always a lady there. And so when a patient has a disease in the breast, besides worrying about the disease and the risk of not being cured, she also has these concerns about the cosmetic outcome of the treatment. And this then leads on to the psychology and the psychological problems that the disease can cause to this individual and her family.
In fact, bringing me on to my next question, as we know and can imagine, a diagnosis of breast cancer affects the patient in many ways more than just physically. As you rightly so mentioned, it affects the woman psychologically and cosmetically. How important is it to take these into consideration when discussing and deciding on treatment options for the patient?
I think it is extremely important. And whilst in the past most patients had a mastectomy, nowadays only about 30% have a mastectomy. And this is restricted to patients who have a very large tumor, where it's not possible to remove it without removing the breast, and also women who have more than one tumor in the breast. So it's important to do a mastectomy. Now these ladies having a mastectomy or offered reconstruction. Reconstruction can be either immediate or it can be delayed. Again, we discuss this with the patient and then they make a decision. Immediate reconstruction usually involves putting in what we call an expander, where there's a bag which is inserted under the pectoralis muscles in the chest, and this is then expanded by injections of saline by a very good nurse that we have on the plastic surgery unit. And once then this muscle and the skin are stretched and expanded to the size which the patient desires, we then do another operation where we change the expander for an implant. Some patients opt to have a mastectomy and then think about having a reconstruction later on, and that can be done too. But the majority of patients only have a part of the breast removed. And we employ techniques which we call oncoplastic breast surgery, where we use plastic surgery techniques to reconstruct the breast at the time when we're removing a part of it. And this is to try and get the best possible cosmetic outcome. I think a good cosmetic outcome is important for the psychology. But then we also have to address the psychology. And sometimes it's enough for me, for the surgeon, for the breast care nurse to speak to the patient. We explain in detail what they're going to undergo and the problems and what they're going to face and what it involves. But there are a sizable number of patients who need more support than that. And we have a clinic psychologist who is also a nurse, and she then helps these patients and their families when there are these psychological problems. And they help them to cope with the trauma of the disease and its treatment.
Earlier on, we mentioned metastasis. Unfortunately, as we know, metastasis can significantly complicate the management and prognosis of breast cancer. What is the incidence of metastasis of breast cancer, and where are the most common locations for the secondary growth from breast cancer to occur? Also, what effect does metastasis have on the prognosis of breast cancer?
Metastasis is when the breast cancer cells leave the breast. They either travel through the blood supply or to the lymphatics, and they spread to other parts of the body. The commonest are lung, liver and bone, but they can also affect the brain and essentially rarely other organs too. When the patient develops metastasis, the prognosis is obviously worse. Though it's not the single prognostic factor, because also the grade of the tumor or the aggressiveness of the tumor is also a very important factor, in a prognostic factor. Whilst up to quite recently, metastasis was something which was extremely difficult to treat and meant that the patient only had a short time to live. There are now so many effective types of treatment, chemotherapies, immunologicals, which are the monoclonal antibodies, the first of which was Herceptin, but now there are many others, that metastatic breast cancer is becoming a chronic condition. It is not treatable, but the patient can live with it now for many years because of these effective treatments. And so we have an increasing number of patients that are living with this metastatic breast cancer, and they live a good life and for quite a long time. So the outlook has changed dramatically up to what it was only a few years ago.
Earlier on, we also mentioned the fact that some patients have a higher risk of developing breast cancer due to a genetic predisposition. Are there tests available to identify this genetic predisposition in our patients? And in the case that a positive result is obtained, does screening vary for the patient? And what is the current stand for prophylactic surgery, risk reduction surgery?
Yes, there is a test that we can do for genetic breast cancer, and this is a simple blood test, though the test itself is very difficult to do in the laboratory. But it's not a matter of just doing the test. It is crucial to speak to these ladies and to counsel them on the implications of this test. Now, we offer the test to ladies who request it when they have relatives who have had breast cancer, especially if they had breast cancer at a young age. I'm talking about relatives who had breast cancer in their 30s or 40s. And we have to explain to these patients that if they are tested negative, in other words, they don't have one of the mutations that we know about at the time, that means that the risk could be equivalent to the normal population, but it might also be higher because there is a genetic mutation which we don't know of or which we haven't tested for. When a patient is tested positive, especially for the common genetic abnormalities, I'm talking on BRCA1 and BRCA2, the risk of getting breast cancer in the lifetime goes up to around 90% from the average 10% for the normal population. And also, if they are going to get a breast cancer, they will probably get it at a relatively young age. So this is a very significant problem. And we have 3 ways of dealing with patients who have a BRCA1 or 2. There's always the option to do nothing, and some patients choose not to test, or if they test, they don't want to do anything about it. Then we have the option of screening a bit more intensively, and this would probably imply having an MRI at a young age, and then going on to mammography maybe at the age of 35 or so. But then there is the option of having risk reduction surgery. And this is a technique where the patient has a bilateral mastectomy and the breast is reconstructed at the same time with silicone implants. But whilst this sounds like a wonderful operation, there are problems. First of all, you cannot ever remove 100% of the breast tissue, so that still leaves them with a small risk of getting a breast cancer. Also, as you can expect, the cosmetic outcome of any mastectomy and reconstruction, though it is very good, will never be the same as breasts in a young lady. And so the patient has to be shown photographs, perhaps meet patients who have undergone this. Nowadays they can see them on YouTube, and then make a good decision after she's been advised and counseled properly.
When a patient undergoes a mastectomy, Is there any support available? Maybe are there any NGOs? Can patients obtain special bras if they have lymphedema issues? What kind of support is available for these patients?
There is support from breast clinic where there are breast care nurses, and in mastectomy cases they give them the external prostheses and special bras, and they're advised on that. But there's also a very good service by NGOs where patients meet other ladies who have gone through this. They meet up and they talk. And these NGOs have been very strong over the decades. They have lobbied very much for the introduction of, for example, Herceptin. And also they have lobbied for the use of information leaflets, which they have provided, and they provide special bras which are used for the prostheses. So there's a lot of support. I think breast cancer is probably one of the diseases or conditions where there's the largest amount of support.
As mentioned earlier, it is well known that, like many other illnesses, breast cancer can affect a patient who has been diagnosed in many other ways rather than just physically. And it is very important that a holistic approach is maintained throughout the treatment. What kind of psychological support is available for patients who have been diagnosed with breast cancer?
As many other conditions, the way a patient copes with a problem like this depends on a lot of factors. An important one is an underlying history of depression, for example, or anxiety, which makes it much more difficult for them to cope with these problems. They have to cope with the problem of the disease itself and also the sequelae of the treatment. I'm talking about surgery, perhaps cosmetic outcome, and of course, if they undergo chemotherapy, there are problems of losing the hair, feeling unwell for several months. So this can be a very stressful period. Of course, the patient does much better when they're supported by their friends and family. But we provide counseling, so we try to allay the patient's anxieties by explaining exactly what they're going through. And this takes time, but it's very important. We have a good breast nurse service, and we also have a psychologist on the unit. But of course, some patients still need even more care than that. And there are many who actually go to a psychiatrist or psychologist outside our unit, and they will need support, perhaps temporarily, and then once the treatment is all over and they're well, they'll go back to their normal selves.
Mr. Caruana Dingley, thank you very much for a very informative session. One last question. Most of our audience are healthcare professionals who will meet a patient who has been diagnosed with breast cancer in many different settings. Some of us will meet him just after diagnosis, others post-op. What is your final take-home message for us healthcare professionals meeting these patients in different settings to strive to give our patients the very best treatment and care we can in what possibly is one of the most delicate phases of their life?
I think the most important message is not to delay. If somebody has a symptom which may well be an early cancer or a sign of a cancer, I think it's important that these patients are referred to our unit where we can assess them as quickly as possible and do our best to give them the best possible treatment that is tailored to their disease and to the individual patient.
Mr. Caruana Dingley, thank you for a very informative session. I invite you viewers of this session to complete this e-learning experience by completing the set of multiple choice questions associated with this session. I also invite you to visit www.thesynapse.net/CME for more e-learning videos.